Hello everyone, can you hear me?
Yeah, we can hear you clearly.
So this is the first case. So a 60-year-old man who was referred by his GP due to leukocytosis. The white cell count is 17. The hemoglobin and platelet counts are normal. So this is the power 10. Now I will go to power 50. Or any comment on this blood thin? Anyone? What are these cells and how would you report the blood thin?
LGL cells.
How did you identify these are LGL cells?
The lymphocytes are a little bit larger and with clear cytoplasm and some having a few granules.
Mm-hmm. How will you determine the clonality in cells?
T cell receptor rearrangements. Because
Mhm. This is correct. And is there any association of these
yeah,
LGL?
it's usually associated with autoimmune diseases.
Extent? Right. So how will you report this blood thin?
If I go by cell line by cell line, so red cells, most of the red cells are nomochromic nomocytic.
Mhm.
Platelets adequate in number and morphology. White cells, leukocytosis with absolute lymphocytosis. Lymphocytes are large lymphocytes with abundant cytoplasm with granules. I haven't seen any blast. And altogether, if I conclude this, the lymphocytosis is could be due to a chronic lymphocytic lymphoma. like a chronic lymphoproliferative disease. Uh, I would suggest further investigations including flow cytometry um, and genetic rearrangements of T cell receptors, and to look for underlying autoimmune disease.
You mentioned this is lymphoproliferative leukemia like CLL.
Sorry, not CLL, chronic lymphoproliferative disorder.
Mhm. Okay. So the lymphocyte count is high. So when you are reporting it, uh, comment on the lymphocyte count first,
Mm-hmm. Yeah.
and then come to the normal cell lines or the other cell lines like
Okay.
RBC
Yeah.
and the platelets. Your impression is that this is lymphoproliferative disorder, and then you have suggested that you do flow cytometry in this patient to confirm the clonality of this case. Okay, so this turned out to be LGL. The clonality is positive.
Mm-hmm.
How would you approach the treatment in this patient?
Uh, lim- Immunosuppression is the mainstay of treatment for these patients. So we can consider about MTX or cyclosporine.
Patient hemoglobin is normal, platelet is normal, white cell count is just 17. Still, you will give him cyclosporine.
No, first of all, we want to see whether there are treatment indications. If patient does not have any underlying autoimmune diseases which is troublesome at the moment, I think I would continue to monitor the patient.
Mhm. Yeah, if the patient is asymptomatic and there are no cytopenias, then usually just monitor him. Uh, if the patient is symptomatic or with cytopenias, yes, then you have immunosuppression
Mhm.
as the treatment of this low dose methotrexate or cyclosporine. Yes. What is the mutation involved in this case?
Stat 5?
And 3 or 5B. They will always ask what are the associated conditions with this. You have to mention the autoimmune disease, especially rheumatoid arthritis or pure red cell aplasia sometimes as well. They are associated with, and now this is the 90-year-old patient who presented to A&E and a bit unwell. His hemoglobin is 101. The white cell count is 62, and the platelet count is 98. This is the power of 10. Now I will go to power 50. move to any comments on this 90-year-old patient blood film? Anyone who can shout out? Russia, can you tell us what is going on here? Yes, Hafsa, your hand is up.
Sorry. Yes, Dr. Amir.
Yeah, this is not
Actually, I'm not sure about the finding because I see immature monocytes, but I cannot appreciate them like pro-monocytes. The patient has also thrombocytopenia. I see a leukoerythroblastic picture, left shift, and I have noticed a single nucleated RBC. So I cannot reach the definite. These are monoblood.
Sorry,
Are these monoblood?
you have to tell me.
Okay.
Can I comment?
Yes,
So you want me to report the film?
yeah.
So the red cells, I think they look unremarkable. I don't know whether this is spherocytes or not, the one in the middle, but the overall picture looks unremarkable. Platelets, there is true thrombocytopenia. White cells, there is...
Comment on the affected line first, please.
Yeah, okay. White cells, there is monomorphic cells with increased nuclear cytoplasmic ratio. There is cytoplasmic vacuolations, slightly opaque chromatin, and there is eosinophilic granulation. So there is our blasts. For differential, I need a flow. It could be the patient is anemic, he's 90-something with thrombocytopenia. It could be dendritic cells, could they are medium to large size, could be diffuse large, could be, so differential of blast with vacuolation. Could be Burkitt, could be BLL.
But these blasts have, some of them have granules.
Yeah, eosinophilic granulation, yeah.
So can it be lymphoma then, if there are granules?
It's usually myeloid in origin if there is granulation.
Yeah. So some of the blast has granules. Some of the blast look like monocyte, pro-monocyte, like these ones. So it will favor more leukemia than lymphoma.
You can't tell without the flow.
Okay. So how will you report it? Is blood film contain lymphocytosis and blood film contain multiple blasts?
So monomorphic cells, medium size, increased nuclear cytoplasmic ratio, cytoplasmic vacuolations with eosinophilic granulations. Need urgent flow to be sent for analysis.
Okay. And what else you will advise?
So the patient is anemic, 101, I think, and platelet is 91. He needs to be admitted under hematology care, and then need assessment, any bleeding, any history first, of course, and to see how the patient he's doing, is he's hiding hemodynamically stable, anything.
Okay.
And then treat accordingly.
Right. So this is myelomonocytic leukemia. All right. You can see multiple blasts. Some of them have granules. Some of them are pro-monocytic. They have a lot of vacuolation with bluish cytoplasm. This is leukemia. Then red cells, they are not okay. They have hypochromia. There are spherocytes. There are teardrop cells. There are some schistocytes as well. So you have to comment on everything that is present in the cell line, because the examiner, when they are marking your morphology paper, they will have all the comments mentioned on the key. If you have not mentioned schistocytes or spherocytes in your answer, they will deduct marks from you. Yes, this patient is thrombocytopenic as well. You have to mention that. Your impression is acute leukemia. This is enough. To differentiate whether this is lymphoma, this is leukemia, or biphenotypic, it will be on the flow. Most of the time, we think that this is ALL. It comes out to be AML on flow. Sometimes we think that this is AML. It comes out to be ALL on the flow. So saying this is acute leukemia is enough. Then yes, we have to send urgent peripheral blood film to for flow cytometry, to admit under hematology and assessment, and to discuss bone marrow biopsy with the patient. Okay. So he has acute myeloid leukemia or acute myelomonocytic leukemia on the flow and bone marrow biopsy. What next? What is the next step
Risk
now?
stratification.
How you would do that?
So you send various cytogenetics and molecular markers. But of course, this patient is 90 years old, so whether or not there is, whether he's even fit for treatment and evaluation of patient's performance status and comorbidities.
Yes. Because when I discuss this with my registrars, everyone starts saying, we will give him flagged IDA, we will give him DA, or we will find out what is his cytogenetics, categorize him intermediate, standard, or worst category. So yes, he has AML, but he is 90-year-old he is not fit for any DA or flagged IDA, or even not fit for an ASA. At 90-year age with multiple comorbidities, I will palliate him. This is important as well to look at the patient age, comorbidities, and then answer in the exam that yes, whatever you say will be correct, but it will not fit this particular patient, which is in your exam scenario. So always tailor your answer according to the scenario given. Yes, if this patient was 40-year-old, then I would have decided whether I should give him DA or flag IDA. This patient's cytogenetics were 6-9, worse category, but because of his age and comorbidities, we didn't give him anything. We just palliated him, and he died after 2 days. This is another case. He is 52-year-old and presented with confusion. The family member said that he had night sweats since a week. He has lost weight and he has a visible lump in the axilla and in the neck area. So this is power 10 of this patient. Now we will go to power 50. Just trying to find the correct cells for you that you can comment on that. It's another cell. It's another cell. I can make it big. You go back to 50 and see some more cells. Not specific.
Sir, can I tell?
Yes.
So first of all, for RBCs, there is microcytic hypochromic. Polychromasia is there. Band cells can be seen. And RBC's count is less.
Mhm. And then
Atypical lymphocytes, you can see.
here's typical of style. I'm trying to maximize the cells for you because these are the abnormal cells
Yes.
that we are seeing here.
Nucleated RBC.
This one, this one is not a big RBC. This is bigger than RBC. So go on, continue with your report.
The immature red white blood cells can be seen, band cells.
Mhm. So compare the size of this cell with these cells. This is not an RBC, this is something else. So I will make it 100 this one, then we can continue your report. Yes, now go on with your report.
So microcytic hypochromic, polychromasia is there in RBCs. RBC count is less. And we can see immature lymphocytes and band cells.
Mhm. Then
So chromatin, there is open chromatin can be seen.
mhm. Then
Size is greater than the normal.
so what do you think? This patient has confusion, he has night sweats, weight loss, lump in the neck and in the axilla. This is the blood thin. What do you think?
Probably we can go for lymphoma if we consider it with the symptoms.
Yes. So, lymphoma. What type of lymphoma do you think?
So sorry, I can't hear you.
What type of lymphoma do you think this patient has? Looking at these cells. Anyone else? Find some another cell for you. This is power 100 of this cell. Myova is there. Myova, what do you think?
Maybe follicular lymphoma, Dr. Amir?
Sorry, which lymphoma?
Follicular lymphoma?
Yes, this is lymphoma because patient has B symptoms, but I want a report and I want to know what type of lymphoma is this. This is a low-grade lymphoma, high-grade lymphoma, and this is the example of cell in front of you.
Yes. Hello?
Yes, Myova.
Yeah, so these are mononucleated cells with increased nucleocytoplasmic ratio with some having more than 3 to 4 nuclei. This looks like, I will say aggressive lymphoma, and my thinking with this one will be maybe a blastoid mantle.
Anyone else has a different opinion about this?
So it can be low grade because band cells can be seen.
Which low grade? What is in your mind of low grade lymphoma?
These cells have cleaved nucleus, maybe follicular lymphoma.
Follicular lymphoma cells are very small, to the size of RBC, or more, a little bit bigger than this.
For Amir, does he have any skin lesion?
Any skin lesion?
Skin lesion?
No. Let's describe this lymphocyte. What do you think the color of cytoplasm is?
Basophilic.
It's basophilic. Basophilic cytoplasm, large cell with nucleoli. This one has one prominent nucleoli and looks like this one as well. So there are two differentials for such.
PLL?
Either it can be large B cell or it can be Burkitt. Burkitt has a bluish cytoplasm like this, but it contains a lot of vacuoles. Or it can be large B cell lymphoma. This patient has confusion. This patient has B symptom. And this patient has large atypical lymphocytes with multiple nuclei. So
Diffuse large B-cell lymphoma.
yeah, this is large B cell lymphoma. Patient is currently inpatient with us, receiving chemotherapy metrics because his disease is mainly in the CNS, and he has a systemic disease as well as CNS disease. So please see the blood film for Burkitt lymphoma and large B cell lymphoma. It must be present in your lab, and it must be present in the NICMA slide as well. It is rare to see high-grade lymphoma in blood film, but when it involves the bone marrow, it can appear in the blood as well. Burkitt lymphoma cells can appear in the blood. Diffuse large B-cell lymphoma can appear in the blood as well. Their cells are very basophilic, like these one. The Burkitt lymphoma cells, they have a lot of speculation, and the Burkitt lymphoma usually present with localized mass either a mass on the jaw, either a mass in the groin area, or in the abdomen anyway, but a single mass. And diffuse large B-cell lymphoma has a lot of lymphadenopathy everywhere in the body. Okay. So this was diffuse large B-cell lymphoma. Another case which was referred to us by a GP because the patient white cell count were high on routine blood tests. This is the power 10, just to show you the slide overview. Now we will go to power 50. Right. You have seen multiple cells. What do you think is going on here? Yes, go on.
Assalamu alaikum, sir.
Salam.
Can I speak? Can I tell you?
Yeah.
Yeah, it's a platelet settlism is going on here around the atypical lymphocytes. These lymphocytes are small to medium in size, high NC ratio with clumped chromatin, and not prominent nuclei. Platelet seems educate with platelet settlism around the atypical lymphocytes, and RBCs are an isopoikilocytosis. And so these findings are suggestive for lymphoproliferative disorder, most likely mantle cell lymphoma.
What is this?
Because this cell,
This one.
this may be debris.
There's much
There
cells.
is This is another. Did you mention this in your report?
Mm.
And when This slide was discussed in the part 2 group. I think no one commented on the liquid cytolism.
Liquid cytolism. I mentioned it. I think I have written this case.
Whatever you see in the blood film,
Yeah.
you have to mention. You have seen smudge cells, you have to mention that. You have seen liquid cytolism, you have to
Yes.
mention. RBC here, they have a lot of different shapes and morphology.
Hmm.
This is a teardrop, this is a teardrop.
Yes.
Some are microcytes, some
Teardrop
are
cells.
normocytes.
Yeah.
You have to comment on everything. So you think this is mantle cell lymphoma? Why you
It is
think this?
lymphoproliferative disorder. But we have to investigate further for immunophenotyping, lymph node biopsy, and fish analysis. The more most likely is mental, I'm saying, because the platelet cytolism is most looking around the mantle cell lymphoma. It is associated with mantle cell lymphoma.
It can happen in any lymphoma. Is there any
Yeah.
specific reason? Is there any specific reason mental towards cytolism?
Yeah, because of specific reason.
Is there any specific reason mental lymphoma would lead to platelet cytolism? I don't know about that reason.
The platelet cytolism is basically because of EDTA clumping, actually, but here in the morphology is most is mental because of it's medium. It's not too much small cells. It's medium sized cells, and there is of course higher NC ratio, but it's not CLL type. It's not follicular type, because follicular type is cleaved in it, and CLL is very small, lymphocytes. So its morphology is more likely to mantle cell.
Okay, so you will always say that this is lymphoproliferative disorder, low grade.
Yeah.
If they give you any flow cytometry, then you can distinguish whether this is CLL or mantle cell. Because if you see the new guidelines of mantle cell lymphoma, mantle cell has many different types, and one of the type is small cell variant as well, I think, if I am not wrong. It has blastoid variant, small cell variant, I think vegetative variant or marginal variant, something like that. But they have described, the guideline have described 5 different types. So it can be any.
Yes.
So they say it is a classic phenotype, pleomorphic and blastoid, small cell variant, marginal zone-like variant, even starry sky pattern seen in blastoid and morphic variants. It has different variants now in the new 2024 guideline. So you always rely on the flow cytometry. Yes, these are medium-sized cells. They are not large, they are not small, and this is a classic phenotype of the mantle cell lymphoma where the nuclear material is a bit square shaped. That's how I identify the classic mantle cell lymphoma of the blood film. But it's difficult to actually identify what type it is. If you have a flow cytometry, then yes, you will identify. So what flow cytometry do you expect in this patient?
Sorry, Dr. Amir. Could you please repeat what is the characteristic morphology of mental?
The mantle cell lymphoma has different subtypes, morphological subtypes. It can be small cell variant, it can be marginal zone variant, it can be classic phenotype, it can be blastoid variant as well. The classic phenotype, which I recognize, is you can see these nuclear material, nucleus, they have a square shape. But whenever I see them under the microscope, I do not say that this is mantle cell lymphoma. I always ask for the flow cytometry to confirm that, because mantle cell lymphoma is very dodgy lymphoma under the microscope.
Thanks.
And you never make any diagnosis on the blood film. You always look at the flow. As I mentioned in the in the second case, that sometimes we think that this film is ALL, it comes out to be AML. Sometimes we think that this film is AML, it comes out to be ALL on flow cytometry. So you never make diagnosis on based on the blood film, seeing blood film on. You always need something else to confirm your diagnosis. But it does not mean that if you have seen bilobed cells, um, you wait for the diagnosis. If you have seen bilobed cells, you have to give
Yes,
your
yes,
patient
sure.
urgent treatment. And then PML RARA stain takes only 1 hour in our hospital. It tells us whether this patient has positive PML RARA stain or negative PML RARA stain, and we take it from there. Okay. So whatever you see in the blood film, it is you have to write that in your paper. Some people in the YouTube commented that this is leishmania. This is not leishmania. Right. Is another patient. Something has happened to the camera. What? So this is another 60-year-old man referred to hematology because of leukocytosis. This is power 10.
Yes, from far is like leukocytosis, lymphocytosis, and so many smudge cells, which may be leading to CLL, but we will see closer.
And now this is power 50. Do you think these cells are different from the previous slide cell?
Yes.
How?
So that cells are um, like these are small cells also, small lymphocytes and slightly big also, like prominent nuclei. But that cells are medium in size and all cells are mononuclear type, means monotonous population, not small and big like same population. And that cells are high NC ratio. Here, the two population is very small lymphocytes and slightly big, like pro-lymph type, with prominent nuclei and with cytoplasm also. And the other one is not like that. So that's the difference for me, I think. And here is too many smudge cells, and there is no smudge cell on that.
There were smudge cells.
Very, very few, right? Here is too many.
Yeah, so smudge cell does not always mean that it will be CLL. They can be present in follicular, they can be present in mantle. These are just burst out uh, lymphocytes during preparation. They can be present anywhere. But these cells are very mature looking, smaller than the previous cells. Their nuclear material is more mature than the previous cells. And yes, they have another population of cells as well, which are called prolymphocytes. And even some of them have the size of a red cell as well. This nucleus and these red cell are very small. And what flow cytometry do you expect in this patient?
Is his Richter transformation?
Transformation too?
So it looks like he was a CLL and transforming into diffuse large
How do you
or Burkitt
say that this patient is transforming to diffuse large?
or Burkitt. I'm not sure.
No, CLL does not transform into Burkitt. It has never happened before that CLL goes into Burkitt. Yes, it can go into
Hodgkin lymphoma.
Richter transformation or Richter transformation, which is DLBCL or large B-cell lymphoma. But these cells are not diffuse large B-cell lymphoma like. Diffuse large B-cell lymphoma or large B-cell lymphoma cells are very big cells. And they have typical morphology, which we have seen in the case number 3. They are large cells with deeply basophilic cytoplasm and sometimes contain 1 or 2 vacuoles and multiple nucleoli.
So what history or what blood? We didn't get any of his blood. You just only said that his white cells is high.
Yes, so here in UK, we have annual blood tests with the GP, and those blood results are then processed in the hospitals. If the white cell count or any parameter of the full blood count is abnormal, blood film is made. So this patient has routine bloods at the GP, and then when the GP saw that this white cell count is high, then he referred the patient to us. His white cell count looks like to be 80 or 90, like that, but he is asymptomatic. He has a normal hemoglobin, he has normal platelet count, he has no B symptoms, he has no splenomegaly. He just needs money. If he had B symptoms or cytopenias, then yes, we would have discussed treatment with him. And if he was transforming to DLBCL, he would have B symptom. He would have lymphadenopathy everywhere in the body, cervical, axillary, groin lymphadenopathy. So that's why it's less likely that he is converting to DLBCL. These cells, these are prolymphocytes, very prominent nucleoli. These are prolymphocytes, which is a part of the CLL. If they are more than 15%, we say that this patient has CLL with the prolymphocytic progression. If these cells are more than 55 cells, then we say that this patient has transformed into another category, which is called SLLPN, splenic lymphoma leukemia with prominent nucleoli, according to WHO 2022 criteria, which we follow here in UK.
Will we have in the exam just a blood film to report, or would we need a flow in order to know the suspected diagnosis?
They will only tell you that this patient has blood test done at GP, and the GP has referred the patient to you with lymphocyte. Please comment on the blood film or report the blood. So you will report this blood film, and then the next question will be, what is the expected flow cytometry in this patient? So I assume you would have make a diagnosis by seeing this film. This patient has mature lymphocytosis, a lot of smudge cells. This is most likely chronic lymphocytic leukemia. So you will write the flow cytometry, expected flow cytometry for the patient. Then they will ask you what are the treatment options for this patient. Then you will say if symptomatic, then another column, non-symptomatic. If symptomatic, then you would see the TP53 status of the patient, comorbidities, and performance status, and decide whether you want to give continuous therapy or fixed duration therapy. And if the patient is asymptomatic, then he needs monitoring. In some of the cases, they may give you flow cytometry as well. And this, the patient presented was with B symptoms. He had a lymph node biopsy, and the flow markers are here. He has a blood film done as well because of cytopenia. Please comment on the blood film. What is the diagnosis? Because they have given you the flow cytometry, and then they will ask you what is the treatment for this patient. Because it is a 10-mark question, 4 to 5 marks are for the reporting, and another 2 or 3 or 2 or 3 marks for the other 2 questions. The total mark for a short case is 10. And you have 9 minutes to see the blood film and to write the answers for each slide.
Thank you.
It can be aspirate, it can be tryptine, and less likely that they will give you a lymph node biopsy or CSF or pleural fluid. I haven't heard about that they have given such thing in exam. This is the last piece. And if you are working in UK, or if you are not working in UK, and you are going for the exam, ask your hematopathologist, consultants, or HNDS or HODS consultants here in UK to arrange exam related slides for you. In UK, you receive the NICWA slides as well. They have a lot of findings, especially the slides of September, which was CDA and the blood film. You must see them. These things appear in the exam as well. So this is the last case. Again, 70-year-old patient presented to ED because of feeling unwell. And this is the blood film. This is power 10. And power 50. So what do you think is going on here?
Any hepatosplenomegaly?
Patient has splenomegaly.
Basophilia in CBC?
Sorry?
Is there any basophilia in the CBC?
I have no CBC in hand. I have only blood film with me.
Patient has marked leukocytosis, total leukocytosis. The left shift up to myelocytes. There is marked monocytosis also.
Mm-hmm.
Some neutrophils show these plastic features. Why this RBCs show some anisocytosis, some macrocytes, some normocytes. Platelets are decreased. There is thrombocytopenia. Does he have infection?
No.
No infection. So most likely MPN, picture of MPN.
Mm-hmm.
So it's
Or sorry. Go on. So I will ask for VCR ABL mutation first, and
VCR
translocation,
ABL,
sorry,
VCR
translocation.
ABL is negative.
can I add, please?
Mm-hmm.
For me, is CMML is myeloproliferative type, subtype, because his WBC count is very high, elderly age, and splenomegaly, and so many monocytes with dysplastic features. And so most likely is CMML. We'll go for further bone marrow biopsy and immunophenotyping, then cytogenetic, basically cytogenetic abnormalities and molecular for confirmation.
Why do you think it is CMML?
Sorry?
Why do you think this is CMML?
Because of monocytes, um, uh, prominent monocytes with display plastic features. And if monocytes is more than one, then and with the dysplastic features is more than 10%, then we can consider the CMML. And of
Which
course,
type?
here is the left shift myeloproliferative. I said myeloproliferative type because of his WBC count is seems more than 13.
One or two?
We will do the blast count. If it's peripheral blood less than 5, it seems less than 5%. So I will say it's one type. But if it is 5 to 19, then we can go for this CMML2. So I hardly see any blast here. One maybe. So it seems CMML1.
Okay. Yes, this is myeloproliferative type of CMML and category 1. There we don't have CMML 0 now because it has been removed by WHO 2022. Right. What prognostic score do we use in CMML?
CPSS mole, something molecular. CPSS.
CPSS more, yes. Right. What treatment can you give this gentleman?
So I will see first the counts if need the supportive care of any blood products or erythropoietin or something. Then of course this is myeloproliferative, so we can start the hydroxycarbamide for leukocytosis, and of course he has splenomegaly also, and hypomethylating agent like azacitidine. And if fit, we will see if the patient is fit. We can consider the allogenic stem cell transplant or any clinical trials.
Yes, his count is very high. You can reduce the count with hydroxycarbamide, and azacitidine is nice approved for CMML patients. So if the MDT agrees, then you can give azacitidine as well. But the important thing is to look for transplant. If patient is fit and agrees and donor is available, transplant after controlling the counts. Right. And this was the last case. We will have morphology session next month again because it's now only once a month. The other Sundays are for 2 sessions. So somebody
Thank you
has
so much.
put something in the chat. Atypical lymphocyte polychromasia, teardrop, stomatocyte, square shape. Can chronic inflammation lead to this? Chronic inflammation would not lead to this much of cells. They are very, very high count. The cell count in the CMML patients were 180. So it's unlikely that infection would lead to this much of leukocytosis. So take care, everyone.